Okay. This goes along with your workbook, so make sure you do the workbook part of this, but it's those same rules. You have to do the true false. Okay, so hospital pharmacy. We're going to talk about hospital pharmacy and then community pharmacy, like just a retail pharmacy. It's really short. So we'll do that in a minute too. Your questions, whenever you get to the exam, can be over both. I mean, you'll see both hospital and retail pharmacy questions on the test. There's not more or less of one or the other. I was talking to my friend Terry, who I say helped me with the math part. We're like, just listen while I figured it out myself. She was like, I think there needs to be a separate test for both because they're so different. But it's important that you study on both, regardless of like you, Jacob, working up here at Miller's.
Yeah.
You know, the retail part of it is going to be a lot easier than the hospital part, and so that's one area you'll want to study for, because it's a lot different. And some of you guys, you followed pharmacists at the hospital, right? And Flo, you did too. So you kind of probably saw a different aspect of it that way. Okay, let's look at this hospital pharmacy. Of course, hospital pharmacy, like we just said, looks a little bit different. Support services, product services, clinical services, educational services. So there's just a lot more, I would say, a lot more involvement of different areas of healthcare probably at the hospital pharmacy versus, retail where you just, it's kind of a routine kind of thing. Hospital is going to have a lot wider array of different things going on. And there's different types of pharmacies even within the hospital. So hospital organization, you have your board of directors there, usually the ones that make the big decisions for the hospital. All of your management. The CEO, you guys have probably heard some of these acronyms before. CEO is a chief executive officer. They're kind of the manager of the hospital, if you will. The chief operating officer, they're probably going to be over more like the support system type of thing. And then chief financial officer, of course, the finances. So you'll hear all of those terms, that's in any management, any kind of facility. So, and then the director of nursing is usually the one who runs all the staffing and the scheduling and all of that stuff for the hospital. There's usually a DON in the hospital, or a nurse supervisor sometimes. You'll hear it called that. You've got your vice presidents, and usually there could be several vice presidents of different things. And then the chief information officer, it's pretty straightforward. So different departments, you guys know this, we've been to a lot of these. So medical staff is responsible for the diagnosis and treatment, what's expected in the hospital, and you guys know this too. Look at this, independent medical practitioners with a private practice. So if you've ever been to the hospital or a family, read all this stuff. If you've ever been to the hospital, they usually have hospitalists. You'll hear that word. So it's going to be your hospitalist. That's a physician who primarily just works there at the hospital, and they manage your care while you're there. It's usually like an internal doctor, internist, somebody who's kind of like the overall go-to, not necessarily just a cardiologist or something like that. Now, you also have doctors who have their own practice but then make rounds in the hospital. So sometimes they work as a hospitalist, or they might just go see their own patients. That doesn't necessarily happen a ton anymore. But a lot of them, I know there's several in Paris that still do that. So sometimes, I guess my point is that you'll get, like for example, when I had my kids, okay, I got a separate bill from the anesthesiologist. It wasn't included in my hospital bill. They have their own billing, their own thing. So that was completely separate. Same thing for the pediatrician who saw them. I got a separate bill from just the pediatrician for those services. So sometimes they're their own, they kind of function as their own entity, but under the hospital or within the hospital. Medical staff. So it says these are elected to govern the medical staff. You have your chairpersons, your directors. That's just kind of like the uppity up end of it. As a pharmacy tech, you're not going to be dealing with this a whole lot, but you'll get a lot of the rules and regulations that trickle down to your job from some of these other areas. Organization of the hospital pharmacy. So you have your professionals. These are your pharmacists and management, the people who've undergone lots of schooling to get to where they are. Your technical staff. This is going to be like your pharmacy tech, somebody who has like a certification or has undergone some kind of classes to do that, but not necessarily like a 4-year, 6-year, 7-year program. And then you have your support staff. These are people who are non-licensed, so they may be handling, the financial aspect of it, or they may handle the stocking or something like that. Okay. Management, of course, you guys know that. Dispensing and preparation. So this could be the pharmacist, pharmacy tech. You have somebody who's maybe specialized in IV mixtures. So that's one thing that when you get into hospital pharmacy, you can specify, there's lots of, whereas retail pharmacy, you don't have a whole lot of IVs and IV mixing drugs, but in the hospital you would. Now there's some, like there is a Paris Apothecary is a pharmacy in Paris that does a lot of compounding. They mix their own drugs, a lot of them. So if you have some kind of random drug that the doctor needs you to get and it has to be mixed in the pharmacy, a lot of times they'll prescribe it and you can get it there. There's a Red River Services, Red River IV Services or something like that. And they primarily do IV medications for home use. And so it's pretty cool because we did lots of IVs at home when I did home health. And so the patient, I probably told them this before, but they would get an individual dispenser of their IV medicine. They would get like 3 days worth at a time. But they're supposed to take it every 8 hours. It looks like a little, kind of like a little lemon or a grenade looking, it's about that size. And it's got automatic pressure in it so that all they would have to do through their IV or their PICC line or whatever they had was clean that and just hook the medicine up to it and it would run in. It was already primed. It was pressurized to go in at the right amount of time. That was pretty cool. So that's something else, mixing wise that they would do. And that included everything. Normally that part of it, like figuring out how fast it needs to go and all that is really a nursing perspective, like a nursing job. But in that case, it's not. Support, of course, again, is your administrative assistant, secretary, buyer, billing, other people who handle that kind of thing. Clinical, so job coordinator, pharmacist, specialist, these people who kind of oversee the aspect of like the patient care part of it. And then of course education. You're always going to have people, somebody who's supposed to be an educator at the hospital, and they're hired that way to do training of new people or whatever. So medication orders, info needed on the order. We know this, we've looked at this before. So their name, height, weight. Why do we need their weight?
So you don't even do with medication?
Yeah. So you want to know, sometimes people don't need as much as, even if they're adults, sometimes they don't need quite as much. They may not weigh very much. Diagnosis, and then of course the allergies. That's always going to be on there. The dosage schedule, the form, and the strength. So how they're supposed to get it, how strong the medicine needs to be, any special instructions, directions for the use, and then of course the route. So remember we talked about the 5 rights. That's kind of like the quick version of this. So right, patient,
right medication,
right med, right way, right what? Way. Route. Yes. Yes. Right route.
Dose.
Right dose.
Time.
Right time. So that's a little more. There's a little more to it pharmacy wise, but that's when you're looking at a patient, you're trying to figure out their medicines. Those are kind of your ways to think about that. Scheduled IV or TPN. Do y'all remember what TPN is?
Sorry, just yesterday.
You what?
Sorry, yesterday real quick.
Total. We have this abbreviation yet? Yeah. Maybe not yet. No, we haven't gotten to the T yet. Total parenteral nutrition.
But
Remember talking about it though? Like it's just an IV fluid. It's all your nutrients, but you get it through an IV. It doesn't ever go through your GI system. Usually looks like milk in the bag. So it's very, definitely a very specialized type of drug for the person, for a specific person. It has to have X amount of calories, has to have all the nutrients you need in it. It's a very, more detailed process of getting it made. And a lot of them are automated, so. Okay, PRN, we know what that means, as needed, so they just take it when they need to. Controlled substances, demand, or stat. If you see stat beside a medication, what does that mean? Right now. Okay, scheduled, these are the ones that are written down on a form to have at a certain time. Emergencies. You'll see there's one example of emergency meds is a car, like the crash cart. You guys have probably heard that term before. Maybe at the hospital you saw it's usually like red. Like in the emergency room there would have been one or a few, probably one in each room even.
they had like one trauma room and they had two in the hallways.
Okay. And then usually each floor will have a crash cart at least, or each section. And basically it has everything you would need in case of like complete, cardiac arrest. So any drugs, they would have their epinephrine in there, any kind of drugs that you would use in that situation would be found in there. So that's another place where drugs would be found, where medications would be found and need to be replenished. And then investigational drugs, of course, we talked about that at the beginning of the year, but lots of documentation with those. Medication dispensing systems. So there are a couple, there's like 2 or 3 on here that we're going to talk about, but they really, over time, it's gotten more accurate, and so we've had less people. The less people that have their hands in the mix in prepping medicine, the less, error typically there is. So, anyways, I got my nursing bulletin yesterday. I should have brought it with me. And this always freaks me out, but there's like pages and pages of people who have gotten their license revoked or reprimanded or completely, and then they always have these pictures of people who have posed as nurses. There's one lady who had been working as a nurse since 2006, and she had just taken somebody else's license number who had the same birthday as her, and that's what she had given them. So when they just ran it through to check, of course, who knows who checked it, they just went through it and it showed up as a license, whatever. Yeah. Isn't that crazy? And scary. And then I think about people mixing meds and things like that. I'm like, oh my gosh. But anyway.
That's crazy.
And some of the nurses who have things on their license, some of them are as simple as they just didn't get it renewed in time, or could be something like that. Now some of them, it's just different things, but they may be under investigation or who knows. So, pretty crazy. But there's lots of them, and that's just for Texas. I just get one for Texas. Anyways, that just made me think of it because I was thinking about, like the less hands that are in it usually is better. You want to, above all else, you want to prevent errors because patient safety is the number one. It is number one on anybody's list in healthcare. It's patient safety, and so you got to weigh that out. But less hands that are in it, the better. So floor stock system is kind of an older system. It's drugs were purchased in bulk in multi-dosage forms, and then they were stored in med rooms. Now there's still some of this. Did all of y'all see a Pyxis machine at the hospital somewhere along the way? It had kind of looks like a refrigerator. Yeah. And it has usually like a clear door or something on the front, and it's got different, just regular medications that you would use. It may have Tylenol,
yeah.
ibuprofen, morphine, specific medicines that you would use all the time that you wouldn't want to necessarily order. So that's kind of this. Of course, like this is talking about, and they used to do that with every medicine, and that made it more of a nursing thing. But pharmacists, I think, have a lot more responsibility than they probably used to have as far as all that goes. Anyway, so that's kind of the same idea. Says then the nurse prepared the medications from that machine or that system or whatever, and then sometimes they would even use the medication on more than one patient, and that still happens sometimes. But in this system, it says the nurse was responsible for most of the steps, and it's just not like that anymore. Pharmacy in the hospital, pharmacies do most of the medication prep, at this point. Most of it. Like I said, disadvantages is lots of med errors. Not that, and especially, like I said, not that nurses don't know, but there's just, pharmacists are medications, like very specialized, look at meds and go from there. Whereas nursing is a lot broader than that. You do need to know the medications, but you also need to know, care for everything else that you're doing. And so that's just a lot, most nurses will get really familiar with the medications that they use most frequently, but not necessarily. Obviously, pharmacists spend 6 or 7 years studying meds, and that doesn't happen for nurses. Potential for med errors, potential for drug diversion and misappropriation. So people not using or using too much, not using too much on the person, but just wasting a lot, something along those lines. It would take a lot more inventory to stock each floor with the amount of medicine that you need than it would be to have one central pharmacy and then ship the medicine out. And then an adequate space. Okay, the patient prescription system is another way. And so it says the information was transcribed by the nurse from the prescription to the medication order form. This is still an older way. You might still do this. You order it. When I was at Children's, this is how it worked, and I have no idea how it works now. This was a long time ago. We would, like the doctor would come in, we still used all paper charting because the emergency room, the rest of the hospital was all on electronic, but the emergency room wasn't yet. And so the doctor would write, there was a specific space for the doctor to write any medication orders. And then if we had an order, we had a pharmacist on staff all the time in the emergency room. So we just called the pharmacist, they had a phone they carried with them, told them we had a new med, and they would come, write it down, and order it. They did all the ordering from the pharmacy. They checked it, and then they would pick it up and check it before we gave it again, usually, unless it was something that was really common or whatever. But they would usually look at it and check it again. So in that particular, this is kind of how we did it, but the pharmacist still actually did the ordering of the medicine. But this one, it says that they dispense a 3-day supply. So if somebody was staying on the floor for a long period of time, order 3 days worth, send it up, and have it for the patient. Says the pharmacy still couldn't properly monitor the utilization, so they may have some left over. Okay, and then the unit dose drug distribution system. This is more like what we have now, so they get what they need at the time when they need it. So it says create a response to an increasing number of new and more complex. Y'all, look at how many medications there are. We've only learned every week, like the top. By the end of the semester, we're only going to have learned like the top 150 drugs, and there are so many out there. Roles of pharmacists and technicians were expanded, so more responsibility. And then the process that evolved was the unit dose, so you get what you need for the day or for that particular dose or whatever. Safest, it's definitely the most efficient and most effective and cost effective for sure, because they're only getting what they need. Copy of the original physician's orders received by the pharmacy, that's what they used to look at. And then medications are prepped, ready to use. They're usually it's kind of like at the nursing home, they come a little blister. A lot of times the nurses will, like a blister. Not a full blister pack like at the nursing home where they had like all 30 months worth of medicines in one pack, but they'll have, like it is whenever you take a box. Like if you take a box of medicine. They come in those little blister pills
Oh,
that
yeah,
you push
yeah,
out.
those.
Individual doses are labeled, and now even this is kind of outdated. You know, a lot of most of the hospitals, everybody's armband has a barcode on it. The medication is going to have a barcode on it. They're going to have to use their scanner to scan the medicine and scan the barcode on the patient's arm. And that's just another way to check and make sure you get the right medicine to the right patient. Pharmacy gets more info this way, and then you don't want to dispense more than a 24-hour system. So definitely reduces med errors because you got less hands in the mix trying to prep medicine. Easier to control, definitely decreases the cost because you're getting less amount of medicine. You're not sending out a whole bunch. Go from there. Okay, sterile products. These are drugs that are given by injection, and obviously hopefully no living microorganisms.
I'm sorry. It's a good thing. Is this?
I think there was no. I had that post. So ophthalmic, what are ophthalmic preparations? Y'all know this. No, that would be otic, ear. Yes, all like an ophthalmologist.
Oh, I thought.
Y'all know that.
All right, I'm down for Southern. But it's
So,
not like any going on term. Which on.
Yeah, I knew Sybil was up
Yeah,
there.
I think it's going on.
No.
I can see your screen checks every time you walk.
oh, yeah.
But
Ointment solutions. So anything for the eye has to be sterile.
Yeah.
Products prepared commercially. Usually things are going to come sterile, like the tablets and everything. And then, of course, you're using sterile procedures. You have proper training. Contaminant free. What areas do they use to keep things sterile? What do they use?
Whatever they're floating.
The flow hood's good.
I don't give them.
So aseptic technique, of course, and then all contents must be chemically, physically, everything has to be compatible. There's some medications, you know how we've been looking at the labels, it talks about.
Good morning, Bulldogs and Dogettes. It is Thursday, April 30th. No birthdays today that we know of.